Good day, my name is Mary and I will be the first reporter under the unit Pain and Inflammation Management Drugs, specifically the anti-inflammatory drugs. Let's begin the discussion with the pathophysiology. We can see in the slide that I have pinned some terms that will be frequently mentioned, as well as a chart or the figure on the pathophysiology of the drug. So let's begin with the tissue injury. So that when a client or we have an injury, there is a reaction called inflammation. So the inflammation on the injured site will cause a release of chemical mediators that will trigger both the vascular response and migration of fluid and cells, specifically our leukocytes or the white blood cells, towards the injured site. So upon the act or there is an injury, there will be vasoconstriction for a moment or momentarily, and then the release of these mediators. These mediators are the histamines, kinins, prostaglandins, and the enzyme called cyclooxygenase or the COX. But along in the discussion, there will be an elaboration of the COX. Let's begin with the histamine. The histamine is the first mediator in the inflammatory process, which causes a dilation of the arterioles as well as an increased capillary permeability, allowing fluid to leave the capillaries and flow into the injured area. Kinins, on the other hand, such as bradykinin, also increase capillary permeability and the sensation of pain. We have the prostaglandin, cause an increase of vasodilation, capillary permeability, of pain and fever. Then, the cyclooxygenase or the COX, which is the enzyme responsible for the conversion of the arachidonic acid into the prostaglandin and their products. So the synthesis of the prostaglandin causes inflammation and pain at the tissue injury. Cyclooxygenase comes in two forms, which is the COX-1 and the COX-2. The COX-1 protects the stomach lining and regulates blood, apil-ani ang atuang blood clotting. Regulates blood platelets. So the COX-2 also triggers inflammation and pain. So anti-inflammatory agents such as NSAIDs or anti-inflammatory drugs and steroids, the cortisone preparations, inhibit chemical mediators and thus decrease the inflammatory process. The illustration that we have here shows the process of how chemical mediators act on injured tissues. These are what we call the 5 cardinal signs of inflammation, specifically the redness, swelling, pain, heat, and loss of function. In this slide, I have a table here, but we're just going to focus on the vasodilation, pain, and fever because chemical mediators such as the complement C3A, C5-3, as well as the interleukins, I haven't discussed that. So let's focus first on the mediators such as the histamine, bradykinin, prostaglandins, as well as the COX. So we have here when there is vasodilation, it means the mediators that is released are histamine, bradykinin, the complement C3A, C5-3, LTC, as well as prostaglandin. And then for our pain, we have the prostaglandin, bradykinin, and histamine. And fever, there is a release of interleukins, the TNF-alpha, and prostaglandins.
Important players, important mediators of inflammation and thus pain. Let us see how it is made. During periods of trauma or injury, many cells around the area, in this case immune cells and damaged skin cells, will convert their phospholipids, their cell membrane, into arachidonic acid. Arachidonic acid, or AA, can be converted to prostaglandin H2. Prostaglandin H2 then becomes prostaglandin E2 and prostaglandin F2. These prostaglandins are the ones that initiate or cause fever, enhance pain, and inflammation. The enzymes responsible for the production of these are cyclooxygenase 1, COX-1, and cyclooxygenase 2, COX-2. Interestingly, COX-1 and COX-2, despite being of the same name really, are very different. You see, COX-1 is always active to maintain homeostasis in our body. It's a good guy. COX-2 is the one active during injury, stress, and trauma. For example, let's take a look at platelets. When we cut ourselves, we need to stop bleeding. Platelets help with this. What happens here is that COX-1 converts arachidonic acid to prostaglandin H2. Prostaglandin H2, as we have just learned earlier, can then be converted to prostaglandin E2 and F2. However, in platelets, something different happens. Prostaglandin H2 is actually converted to thromboxane A2. Thromboxane A2 is a chemical causing platelet aggregation to help stop bleeding.
Here, I got this chart from our book. So we have the 5 cardinal signs. redness or erythema. So when there is redness, we would know, or we should think that this is the first phase of inflammation because the blood accumulates in the area of the injury because of the release of the body's chemical mediators, that is the kinase, prostaglandin, and histamine. These chemical mediators dilate the arterioles. And then the second phase of the inflammation, which is edema or swelling. Plasma leaks into the interstitial tissue at the injury site, and kinase and histamine increase capillary permeability. Then heat. Heat at the inflammatory site can be caused by increased blood accumulation and may result from pyrogen substances that produce fever, which interfere with the temperature-regulating center in the hypothalamus. The fourth cardinal sign is pain. Pain is caused by the swelling, tissue swelling, and release of chemical mediators. And lastly, the loss of function. So loss of function because of the accumulation of the fluid at the tissue injury site, and because of pain, which decreases mobility at the affected area. So earlier I pinned terms such as the vascular phase and the delayed phase. So ato ang inflammation, we have two phases. We have the vascular and the delayed. The vascular phase occurs about 10 to 15 minutes after an injury, and then the vascular phase also is associated with vasodilation and increased capillary permeability, during which blood substances and fluid leave the plasma and go to the injured site. On the other hand, ang delayed phase occurs when ang leukocytes na ang ma-infiltrate within the inflamed tissue. Anti-inflammatory agents. So these anti-inflammatory agents helps relieve pain. Our drugs under the category analgesics reduce elevated body temperature, our antipyretics, and then inhibit platelet aggregation or anticoagulants. These drugs, such as aspirin, inhibits the biosynthesis of prostaglandin and are therefore called prostaglandin inhibitors. Because prostaglandin inhibitors affect the inflammatory process, there are commonly called anti-inflammatories or anti-inflammatory drugs. So the NSAIDs include aspirin, and aspirin-like drugs inhibit the enzyme COX. So I have introduced COX earlier. This is needed for the biosynthesis of the prostaglandin. So these drugs may be called prostaglandin inhibitors with varying degrees of analgesics and antipyretic effects, but they are primarily as anti-inflammatories to relieve inflammation and pain. Their antipyretic effect is to lessen temperature as well. The preferred drugs for headache and fever for adults is aspirin, and then they have acetaminophen and ibuprofen. The NSAIDs are appropriate for reducing swelling, pain, stiffness in their joints, and then most NSAIDs cost more than aspirin. Other than aspirin, the only NSAIDs that can be purchased over the counter or OTC are ibuprofen and naproxen. All other are meloxicam, oxaprozin, nabutimone, solindac, and ketorolac. If a patient can take aspirin for inflammatory process without the GI system being upset, salicylate products are usually recommended. So salicylate under ANA is ato ang aspirin. So our NSAIDs are divided into 7 categories. And the 7 categories are also divided into 2 generations. The 2 generations, the basis for the division of generation is through the inhibition of the COX enzyme. I will explain further. So let's begin with the first generation NSAIDs, which contains 6 categories. These are the salicylates, the para-chlorobenzoic active acid derivatives or indoles. We have also the phenylacetate acids, the propionic acid derivatives, phenamates, and oxycams. Then, for the second generation NSAIDs, that is the selective COX-2 inhibitors. So this is an aspirin. So aspirin is the oldest anti-inflammatory drug, but was first used for its analgesic, and antipyretic properties. Although these drugs have potent anti-inflammatory effect that mimic the effect of corticosteroid or our steroids, they are not chemically related to corticosteroids and therefore are called non-steroidal anti-inflammatory drugs or fall under the NSAIDs. Most NSAIDs are used to decrease inflammation and pain for patients who have some type of musculoskeletal conditions. Aspirin and other NSAIDs relieve pain by inhibiting the COX enzyme, which is needed for the biosynthesis of our prostaglandin. So earlier, ako ang mentioned that there are 2 forms of our cyclooxygenase, which is the COX-1 and COX-2. So COX-1 serves to protect stomach lining, decrease fever, and promotes platelet aggregation or blood clotting. And then the COX-2 triggers pain and inflammation. What happens with aspirin and NSAIDs is that usually they inhibit or both block COX-1 and COX-2. So the inhibition of COX-1 produces the desired effects of decreasing platelet aggregation but napachay undesirable effect, which is mo-decrease po ang iyang protection for the stomach lining. Therefore, there is always a side effect or sometimes adverse effect of stomach bleeding and ulcers which occur when taking aspirin or salicylates and other NSAIDs agents. So when COX-2 is inhibited, pain and fever are reduced and inflammation is suppressed, but COX-2 inhibitors do not cause gastric ulceration and they have no effect in our platelet function. So the inhibition of COX-1 and COX-2 are often noticed in the first generation. So whenever we give medications under the first generation na mga NSAIDs, always jud na atong i-take consideration effects na sakit sa tiyan or there will be or any problems in the GI system. So the newer NSAIDs or the second generation called the COX-2 inhibitors block only the COX-2 and not the COX-1. So the COX-1 can still do its purpose, which is to protect stomach lining and promote blood clotting, as well as so wala tayo gastric bleeding or ulcer result, but still deliver relief, pain, and inflammation. A COX-2 inhibitor approved by the US FDA is celecoxib. So celecoxib is under the second generation drugs. So drugs similar to COX-2 inhibitors include meloxicam and nabutamoline, which allows some stomach protection. Patients at risk for stroke or heart attack who take aspirin to prevent blood clotting or decrease platelet aggregation would not benefit from the COX-2 inhibitor because if COX-1 enzyme was not blocked, increased blood clotting would remain even though the stomach lining is protected. So we have the different types of salicylates. Let's begin with aspirin. So this is used for mild to moderate pain of osteoarthritis and RA or rheumatoid arthritis. It can cause rash, headache, GI distress, said earlier, and GI bleeding and elevated hepatic enzymes. The other is the diflunisal. So this is for ulcerative colitis. It may cause headache, arthralgia, and GI distress. For the salicylates derivative, we have the oxalazine sodium and the sulfalazine. So similar sila for the ulcerative colitis, but ang sulfasalazine kay may use siya pwede for the rheumatoid arthritis. The oxalazine sodium can cause headache, arthralgia, and GI distress, while the other drug can cause dizziness, rash, headache, GI distress, and oligospermia. So always present ang atuang GI distress. Let's move on to the para-chlorobenzoic acids. So one of the first NSAIDs introduction was indomethacin, which is a para-chlorobenzoic acid. So this is the indomethacin, which is the left, the box there is the left side sa atuang slide. It is used for rheumatoid arthritis, gouty arthritis, and osteoporosis, and it is a potent prostaglandin inhibitor, which means there is a high protein bound, which is 99%. And this displays other protein-bound drugs, which results in a potential toxicity, and has a moderate half-life of 2.6 to 11.2 hours. Indomethacin is irritating to the stomach and should be taken with food. Two other para-chlorobenzoic acid derivatives are solindac and tolmetin, which produces less severe adverse reactions than indomethacin. So tolmetin is not as highly protein-bound as indomethacin and solindac, and it has a short life. This group of NSAIDs may cause sodium and water retention and increase blood pressure. So let's meet these drugs. For our indoles, we have the indomethacin, which is used for mild to severe pain, acute gout, tendinitis, ankylosing spondylitis, and arthritis. It can cause dizziness, headache, GI distress, and GI bleeding. So remember, when given indomethacin, we should give it with food. Then we have the solindac for arthritis, uritis, ankylosing spondylitis, and tendinitis. So similar sa sayahang side effects, dizziness, headache, rash, GI distress, elevated hepatic enzymes, and GI bleeding. Then they have the tolmentin for osteoarthritis, rheumatoid arthritis, and juvenile rheumatoid arthritis. Can cause dizziness, headache, asthenia, weakness, edema, weight loss or weight gain, hypertension, GI distress, and stroke. Off to the third category, which is the phenylacetate acid derivatives. So the phenylacetic acid derivatives, one of the example of the drug is diclofenac sodium, which has a plasma half-life of 2 hours. It is an analgesic and has anti-inflammatory effects that is similar to those of aspirin, but it has minimal to no antipyretic effects. So if ever lantanon siya, dili siya effective because no antipyretic effects. It is indicated for rheumatoid arthritis, osteoarthritis, and ankylosing spondylitis. Diclofenac is available in oral or extended release and topical 1% gel preparations. Side effects and adverse reactions are similar to those of NSAIDs with far less detrimental reactions when using a topical preparation. Ketorolac is another drug of phenylacetic acid derivative. It is the first injectable NSAID. Like other NSAIDs, it inhibits prostaglandins synthesis, but it has greater analgesic properties than other inflammatory agents. Ketorolac is recommended for short-term management of pain. For post-surgical pain, it has shown analgesic efficacy equal or superior to that of the opioid analgesics. It is also administered intramuscularly in doses of 30 to 60 milligram every 6 hours for adults. Ketorolac is also available in oral, intravenous, and intranasal preparations. So these are our phenylacetic acid na medications, the diclofenac sodium, etidolac, and the ketorolac from methamine. So similar with the indications for mild to severe pain, rheumatoid arthritis, osteoarthritis, and spondylitis. And then, sa ato lang ketorolac is that for short-term moderate to severe pain management for 15 days or less and for ocular inflammation. Then to another category, which is our propanoic acid derivatives. So the propanoic group is relatively a new group of the NSAIDs. These drugs are aspirin-like but has a stronger effect and create less GI irritation. So if i-compare sila, mas grabe jud maka-affect sa GI system ang atong aspirins. Drugs in this group are highly protein-bound, so drug interaction may occur, especially when given with another high protein-bound drug. Propanoic acid derivatives are better tolerated than other NSAIDs. Gastric upset occurs, but it is not as severe as with aspirin and indomethacin. Severe adverse reactions such as blood dicrashes are not frequently seen. Ibuprofen is most widely used propanoic acid and also one of the purchased OTC in lower doses. So 200 mg ang available sa atoang ibuprofen when buying. Other propanoic acid agents are phenoprofen, calcium, naproxen, ketoprofen, florbiprofen, and oxaprozin. So earlier I said na one of the OTC drugs pod is naproxen. So we are in the examples of under this category: the phenoprofen calcium, the florbiprofen sodium, and the ibuprofen. So these are for indications for mild to moderate pain, osteoarthritis, and rheumatoid arthritis. For the ibuprofen, this is to reduce inflammatory process, to relieve pain, anti-inflammatory effect for arthritic conditions, and to reduce fever. We have also other drugs such as the ketoprofen, naproxen, and oxaprozin. On to the next category, we have oxycams. So the example for oxycams are piroxicam and meloxicam. So oxycams are indicated for long-term arthritic conditions such as rheumatoid arthritis and osteoarthritis. They too can cause gastric problems such as ulceration and epigastric distress, but the incidence is lower than for more than other NSAIDs. Oxycams are well tolerated, and their major advantage over other NSAIDs is that they have long half-life, so you can allow them to be taken once daily. Full clinical response to piroxicam can take 1 to 2 weeks, and this drug is also highly protein-bound and may interact with another highly protein-bound drug when taken together. Piroxicam should not be taken with aspirins or other NSAIDs, because aspirin is also highly protein-bound, 99%, so possible there is toxicity. So we have here the piroxicam and meloxicam for long-term arthritis or rheumatoid arthritis. The side effects includes edema, and then we also have stroke here for the piroxicam. Then we have the phenamates. So the phenamate group includes potent NSAIDs used for acute and chronic arthritic conditions. As with most NSAIDs, gastritic irritation is a common side effect. Patients with a history of a peptic ulcer should avoid taking phenamates. Other side effects include edema, dizziness, tinnitus, and pruritus. The two phenamates are meclofenamate sodium and monohydrate and mefenamic acid. So we have the antidote. In this slide, you can see the indications and the possible side effects when drinking melacofenamate and mefenamic acids. So, naabot na dito sa ato ang second generation drug, which is the selective COX-2 inhibitor. This is available in several years to decrease inflammation and pain. Most NSAIDs are non-selective inhibitors that inhibit COX-1 and COX-2. So, just a review, when we inhibit COX-1, this is to protect the lining, stomach lining, and clotting time. So, and that means that is the purpose of the COX-1. So, but when we inhibit COX-1, the protection of the stomach lining is decreased as well as the clotting time. So, ang atong arthritic conditions need high doses of anti-inflammatory drugs because large doses of NSAIDs may cause peptic ulcer and gastric bleeding. Currently, one drug, celecoxib, is classified as COX-2 inhibitor. Nabutamone is a similar drug that can be used, however, it is not considered a true COX-2 inhibitor, although mabilong siya na naga-inhibit siya of COX-2 more than COX-1. So this is celecoxib. This is the only drug under sa COX-2 inhibitor. This is to treat osteoarthritis and rheumatoid arthritis, to relieve dysmenorrhea, and moderate to severe pain for ankylosing spondylitis. Then, another drug na nag-inhibit more on COX-2 is the nabumetone. So let's go back to aspirins. So when we have patients who are taking aspirins, so to assess them, we have to determine any medical history. We have to ask the patient if they have gastric distress, gastric bleeding, or liver disease because ang atong aspirin inhibits more of COX-1. And then we have to also obtain a drug history report if there is a drug-drug interaction. Why? Again, aspirins is highly protein-bound. For the nursing diagnosis, we have injury risk for pain, chronic related to tissue swelling, or rheumatoid arthritis. Then, for the planning, we have to make sure that the pain will be reduced within 12 to 24 hours, and then the inflammation will be reduced within a week. For the nursing interventions, we have to monitor serum salicylate aspirin level when a patient takes high doses of aspirin for chronic conditions such as arthritis. The normal therapeutic range is 15 to 30 mg per dl. Mild toxicity occurs at a serum level greater than 30 mg over dl, and severe toxicity occurs about 50 mg over dl. We have to observe the patient for signs of bleeding such as dark diary stools, bleeding gums, petechiae, ecchymosis, and purpura, which is large red spots when patient is taking high doses of aspirin. For the patient teaching, we have to advise the patient not to take aspirin with alcohol or with drugs that are high in protein. And then we have to suggest that patients inform their dentist before a dental visit if they're taking high doses of aspirin because they might have bleeding. And then instruct patients to discontinue aspirin approximately 7 days before surgery to reduce risk of bleeding with the healthcare provider approval. Because may decrease po, di ba, ang clotting if you take the aspirin. And then we have to advise patients to keep aspirin bottles after reach of children. Educate parents to call the Poison Control Center immediately if a child has taken a large or unknown amount of aspirin or acetaminophen. And then warn patients not to administer aspirin for virus or flu symptoms in children. Reye syndrome, such as vomiting, lethargy, delirium, and coma, have been linked with aspirin and viral infections. So acetaminophen is usually prescribed for cold and flu symptoms. We also have to inform patient that aspirin tablet can cause GI distress. Inform patient with dysmenorrhea to take acetaminophen instead of aspirin 2 days before and during the first 2 days of menstrual period. For the side effects, we have to direct patients to report any side effects such as drowsiness, tinnitus, ringing in the ear, kasi makabantay sila ana when they're taking aspirin, headaches, flushing, dizziness, GI distress, GI bleeding, and visual changes and seizures. So we would know if there is GI bleeding with the stools. The diet, you have to instruct the patients to take aspirin and ibuprofen with food at mealtime or with plenty of fluids. Easy aspirin help prevent GI distress or enteric-coated. Ang ato ang cultural considerations is to provide an additional explanation as needed related to the purpose of the drugs and its side effects, as well as you have to evaluate if the effectiveness of the aspirin is relieving pain. If pain persists, another analgesic such as ibuprofen may be prescribed. And lastly, determine whether the patient shows any signs of side effects of aspirin. Remembering that the general side effect or the adverse reaction with the first general NSAIDs is that they inhibit more COX-1 than COX-2. So most NSAIDs tends to have fewer effect than aspirin when taken at anti-inflammatory doses, but gastric irritation is still a common problem when NSAIDs are taken without food. In addition, sodium and water retention may occur, so alcoholic beverages consumed with NSAIDs may increase gastric irritation and should be avoided. And the use of NSAIDs in older adults. So we have noticed na there is always osteoporosis, arthritis. So older adults frequently use this to treat inflammatory conditions such as what you mentioned now, osteoarthritis, RA, and neuromuscular skeletal disorders. So as older adults age, the number of drugs taken daily also increases. So there is a drug interaction, and this is more common, especially when the numerous drugs are taken with NSAIDs. With the use of NSAIDs, GI distress, including ulceration, is 4 times more common in older adults, and hospitalization is often necessary. The introduction of COX-2 inhibitors, second-generation NSAIDs, has decreased the incidence of GI problems associated with NSAID use. However, there is edema is likely to occur. Renal function should be evaluated, and older adults should increase their fluid intake for adequate hydration. To decrease possible complication, the NSAID dose should be lowered. So this ends my report. On to the next reporter, which is Nicole.
Hi, I'm Nicole, and I'll be continuing the report.
So I'll start with the corticosteroids. So corticosteroids is a group of drugs that controls inflammation by suppressing or preventing many of the components of the inflammatory process at the injured site. So corticosteroids have been widely used or prescribed for arthritic conditions, and although they are not the drug of choice for arthritis because of their numerous side effects, they are frequently used to control arthritic flare-ups. So corticosteroids such as prednisolone, and dexamethasone are frequently used as anti-inflammatory agents. The half-life of a corticosteroid is long, more than 24 hours, and it is administered once a day in a large prescribed dose. We have to remember that when discontinuing long-term steroid therapy, the dosage should be tapered over a period of 5 to 10 days. So now let's move on with the disease-modifying anti-rheumatic drugs, or the DMARDs. So when NSAIDs do not control immune-mediated arthritic disease sufficiently, other drugs, although more toxic, can be prescribed to alter the disease process. The disease-modifying anti-rheumatic drugs include immunosuppressive agents, immunomodulators, and antimalarials. So these drugs help alleviate the symptoms of rheumatoid arthritis for 2 million persons in the United States affected by the disorder. So other indications for use of the DMARDs include osteoarthritis, psoriatic arthritis, severe psoriasis, ankylosing spondylitis, Crohn's disease, and ulcerative colitis. Under the DMARDs includes the immunosuppressive agents. So immunosuppressives are used to treat refractory rheumatoid arthritis that does not respond to anti-inflammatory drugs. So in low doses, selected immunosuppressive agents have been effective in the treatment of rheumatoid arthritis. So drugs such as azathioprine, cyclophosphamide, and methotrexate, which are primarily used to suppress cancer growth and proliferation, might be used to suppress the inflammatory process of rheumatoid arthritis when other treatments fail. So there is one study of patients receiving cyclophosphamide. Few new erosions of joint cartilage were present, suggesting that the disease process was not active.
Next is the immunomodulators, which is still under the disease-modifying anti-rheumatic drugs. So immunomodulators are used to treat moderate to severe rheumatoid arthritis by disrupting the inflammatory process and delaying the disease progression. Interleukin-1 receptor antagonists and tumor necrosis factor blockers are two groups of drugs that are classified as immunomodulators. So interleukin-1 is a pro-inflammatory cytokine that contributes to synovial inflammation and joint destruction. So anakinra, which is interleukin-1 receptor antagonist, blocks the activity of interleukin-1 by inhibiting it from binding to interleukin receptors that are located in the cartilage and bone. So the peak of this drug, anakinra, is 3 to 7 hours, and its half-life is 4 to 6 hours. So anakinra is administered subcutaneously. Meanwhile, TNF blockers bind to TNF and block it from attaching to TNF receptors on synovial cell surfaces. So by neutralizing the TNF, which is a contributor to synovitis, the inflammatory disease process is delayed. So an example of a TNF blocker is etanercept, which is actually the first TNF blocker to be developed. So etanercept is administered subcutaneously, same as the anakinra, and its half-life ranges from 72 to 132 hours. So it actually takes quite long for this drug to be excreted from our body. So the signs and symptoms of rheumatoid arthritis are actually suppressed rapidly with etanercept therapy, but they reappear after the drug is discontinued. Other TNF blockers include infliximab, adalimumab, and leflunomide. So both interleukin-1 and TNF blockers predispose a patient to severe infections, so they are contraindicated in active infections and should be discontinued when an infection occurs. So another fact about immunomodulators is that they are actually very expensive compared to over-the-counter drugs like NSAIDs. Now I'll be discussing the nursing process of the drug infliximab. So infliximab is the generic name, and Remicade is the brand name of this drug. So for the assessment, we should first determine the medical history of our patient. We're going to ask our patient if there are any history of seizures, diabetes mellitus, multiple sclerosis, kidney or liver disease. Aspirin can cause gastric irritation, so it prolongs the bleeding time by inhibiting platelet aggregation. Next is we're going to obtain baseline complete blood count and renal and liver function tests. So possible nursing diagnosis for infliximab is mobility, so impaired physical related to severe pain, and chronic related to tissue swelling from rheumatoid arthritis. As for the planning, our objective is that our patient's pain will be reduced within 12 to 24 hours, and the patient's inflammation will be reduced within 1 week. As for the nursing interventions, so the first one would be we're going to obtain a negative tuberculosis skin test prior to initiating infliximab therapy, just to see if our patient is reactive to this drug, to see if there are any allergic reactions. Next is we're going to monitor our patient for signs and symptoms of infection. So if a serious infection occurs while a patient is receiving infliximab therapy, antibiotic therapy should be initiated and infliximab should be discontinued immediately. So next is we're going to monitor lab tests for blood dyscrasias through the CBC and renal and liver function. So we're going to watch out for the blood urea nitrogen, the serum creatinine, alkaline phosphatase, aspartate aminotransferase, and alanine aminotransferase. Next is that we're going to flush the IV tubing with normal saline before and after administration, and then we'll deliver the IV medications through a 1.2 micron or smaller filter. we're then going to administer each dose over a minimum of 2 hours. So we have to remember that we're going to discontinue the IV dose of infliximab if the patient develops acute infusion reaction like chest pain, fever, chills, dyspnea, pruritus, urticaria, hypotension or hypertension. Then we're also going to monitor our patient up to 2 hours after infusion to see if there are any acute infusion reaction. For the patient teaching, so we're going to encourage our patient to keep medical appointments and to have regularly scheduled laboratory tests that include complete blood count and renal and liver function tests for early detection of blood dyscrasias and renal and liver damage. We are also going to advise our patient to avoid live vaccines. So while taking infliximab, because this may cause severe systemic disease by way of viremia or bacteremia. So as for the side effects, we're going to teach our patient to report dizziness, chills, depression, dyspnea, if there are any severe infections, seizures, fatigue, or rash immediately. We're also going to teach them to report severe infections immediately. As for the evaluation, we're going to evaluate our patient's response to the disease-modifying anti-rheumatic drugs, and if pain persists, the drug regimen may need some modification. We're also going to determine the presence of adverse reaction. So if there are any adverse reactions, the drug therapy for pain may need to be changed or modified. The last drug under the disease-modifying anti-rheumatic drug is the anti-malarials. So anti-malarials drugs may be used to treat rheumatoid arthritis when other methods of treatment fail. So the mechanism of action of these drugs, the anti-malarials, is still unclear in suppressing the rheumatoid arthritis. So the effect may take 4 to 12 weeks to become apparent. So anti-malarials are usually used in combination with NSAIDs in patients whose arthritis is not under control. Now that we're done discussing the disease-modifying anti-rheumatic drug, let us now move on with the anti-gout drugs. So gout or gouty arthritis is an inflammatory condition that attacks joints, tendons, and other tissues. The most common site of acute gouty inflammation is at the joint of our big toe, which you can see here in the picture that I provided. So gout is characterized by a uric acid metabolism disorder and a defect in purine metabolism, which results in an increase in urates or uric acid salts and an accumulation of uric acid by the kidneys. So uric acid solubility is poor in acid urine, and urate crystals may form, causing urate calculi. Let us now talk about the anti-inflammatory drug, gout drug, colchicine. So colchicine was actually the first drug that is used to treat gout, and it is introduced in 1936. So colchicine inhibits the migration of leukocytes to the inflamed site. So it is actually effective in alleviating acute symptoms of gout, but is not effective for decreasing inflammation that occurs in other inflammatory disorders. Colchicine does not inhibit uric acid synthesis and does not promote uric acid excretion. It should not be used if the patient has severe renal, cardiac, or GI problems. So again, it's contraindicated with patients who have severe renal, cardiac, or GI problem. Gastric irritation is also a common problem. So we have to remember that our patients should take this medicine with food. With high doses, nausea, vomiting, diarrhea, or abdominal pain occurs in approximately 75% of patients that are taking this drug. As for its absorption, colchicine is well absorbed in the gastrointestinal tract. Its peak concentration time is within 2 hours, and this drug is mostly excreted in the feces, but 10% to 20% is excreted in the urine. Next is the uric acid biosynthesis inhibitors. So allopurinol, which is first marketed in 1963, is not an anti-inflammatory drug. Instead, it inhibits the final steps of uric acid biosynthesis and therefore lowers the serum of uric acid levels, which then prevents the precipitation of an attack. So this drug, allopurinol, is frequently used as a prophylactic to prevent gout, and it is a drug of choice for patients with chronic tophaceous gout. Allopurinol is also indicated for gout patients with renal impairment. It is useful for patients who have renal obstructions that are caused by uric acid stones and for patients with blood disorders such as leukemia and polycythemia vera. It is also given to patients who do not respond well to uricosuric drug like probenecid. So when our patient is taking allopurinol, we are going to recommend them to increase their fluid intake to promote diuresis and alkalinization of the urine. As for the pharmacokinetics of the allopurinol is well absorbed from the GI tract. Biosynthesis of uric acid occurs in the liver in pure form and as active metabolites. The half-life of allopurinol is the drug itself is 1 to 2 hours and is about 20 to 24 hours for its active metabolites. The protein binding percentage of allopurinol is unknown. As for the excretion, approximately 80% to 100% of allopurinol and its metabolites are excreted in the urine. For the pharmacodynamics, allopurinol inhibits production of uric acid by inhibiting the enzyme xanthine oxidase, which is needed in the synthesis of uric acid. Allopurinol also improves the solubility of uric acid. Its onset of action occurs within 30 to 60 minutes. Its peak time averages from 2 to 4 hours, and its allopurinol has a long duration of action. Next is the uricosurics. So uricosurics increase the rate of uric acid excretion by inhibiting its reabsorption. These drugs are effective in alleviating chronic gout, but they should not be used during acute attacks. Probenecid is a uricosuric that has been available since 1945. This drug, probenecid, blocks the reabsorption of uric acid and promotes its excretion. Probenecid can be taken with colchicine. To begin initial therapy for relieving symptoms of gout and inhibiting uric acid reabsorption, small doses of colchicine should be given before adding probenecid. If gastric irritation occurs, probenecid should be taken with meals. Probenecid has an average half-life of 1.7 to 31.2 hours and is 34% to 44% protein bound. Another uricosuric is sulfenpyrazone. So this drug is a metabolite of phenylbutazone and is more potent than probenecid. Sulfenpyrazone should be taken with meals or with antacids to prevent gastric irritation. Severe dyscrasias may also occur, especially in patients with a history of blood dyscrasias. As for its side effects and adverse reactions, side effects may include flushed skin, sore gums, and headache. Kidney stones resulting from the uric acid could be prevented by increasing water intake and maintaining a urine pH above 6. Another adverse reaction is the blood dyscrasias, although this occur rarely. Aspirin should be avoided because it causes uric acid retention. So now I'm going to discuss the nursing process of the anti-gout drug allopurinol. As for the assessment, first we're going to obtain a medical history of any gastric, renal, cardiac, or liver disorders. We have to remember that anti-gout drugs are excreted via kidneys, so sufficient renal function is needed. So if there is any renal disorders, the drug dosage and drug selection might need to be changed. After that, we're now going to obtain a drug history and report any possible drug-drug interactions. Third, we're going to assess the serum uric acid value for future comparisons. And fourth, we're going to record urine output for future comparisons. And then we're going to check laboratory tests such as the blood urea nitrogen, serum creatinine, ALP, AST, ALT, and lactate dehydrogenase, and then compared it with future laboratory test results. Possible nursing diagnosis for this drug is related to the tissue integrity. Specifically impaired related to inflammation of the great toe. And second nursing diagnosis is acute pain related to tissue swelling. As for the planning, our objective for the when our patient is taking this drug, allopurinol, is that our patient's pain from gout will be absent or controlled without side effects. As for the nursing interventions, first we're going to report any gastrointestinal symptoms, gastric pain, nausea, vomiting, or diarrhea for patients taking anti-gout drugs. And also we're going to administer these drugs with food since common siya na maka-irritate sa itong gastrointestinal. So we have to recommend our client to really take some food when taking these drugs. Next is we're going to record the urine output because the drugs and uric acid are excreted through the urine. Kidney stones might occur, so both water intake and urine output should be increased. Next is we're going to monitor laboratory tests for renal and liver function, and watch out for the blood urea nitrogen, serum creatinine, the ALP, AST, and ALT. As for the patient teaching, we're going to encourage our patient to keep medical appointments and to have regularly scheduled laboratory tests for renal and liver function and CBC. Some anti-gout drugs may cause blood dyscrasias, so blood tests should be monitored. Next is we're going to instruct our patient to increase fluid intake as this will increase drug and uric acid excretion. As for the side effects, we're going to advise our patient to report to a healthcare provider any side effects of anti-gout drugs such as anorexia, nausea, vomiting, diarrhea, stomatitis, dizziness, rash, pruritus, and metallic taste. We're also going to advise them to have a yearly eye examination because visual changes can result from prolonged use of allopurinol. For their diet, we're going to warn patients to avoid alcohol and caffeine intake because this can increase their uric acid levels. Next, we're going to suggest to our patients not to take large doses of vitamin C as this will cause kidney stones to occur. Next, we're going to tell our patients not to ingest foods high in purine content such as salmon, gravy, organ meats, and sardines and legumes, since foods with high purine increases uric acid levels. We're also going to direct our patients to report any gastric distress and always encourage them to take anti-gout drugs with food during mealtime. For the evaluation, we're going to evaluate their response to the anti-gout drug, and if pain persists, the drug regimen may need to be modified. And lastly, we're going to determine the presence of adverse reaction. So drug therapy for gout pain may need to be changed if there are any adverse reaction.